Now we are going to examine a patient with an ulcer. Actually, the ulcers of the lower limb, most of these ulcers are either three things. Either venous ulcer, ischemic ulcer, or neuropathic ulcers. So we examine the patient in two positions, while the patient is standing and while the patient is lying down. If the patient is standing, I am trying to be at a level which allows me to examine this patient like sitting down like that or squatting down. We are going to expose both sides, not only one side. I am at the front of the patient and a little bit towards the side that I am examining. What am I going to notice about this patient? First, I am going to describe the ulcer itself, and then I am going to examine for the causes of this ulcer. The causes, as we said, either venous, so I am going to examine the venous system, then I am going to examine the arterial system, the pulsations, and then we are going to examine for any spread from this ulcer to the lymph nodes, whether it is inflammatory, enlargement of the lymph nodes, like in cases of septic secondary infection of these ulcers, causing, of course, inguinal lymphadenitis, or if it is a malignant ulcer, then it is going to be some hard lymph nodes of the inguinal area. So we are going now to describe the ulcer itself. Then we are going to examine venous, arterial, and inguinal lymph nodes. We can look at the lower limb as a whole, and then we are going to see here things other than the ulcer itself. By inspection, we can see an ulcer. Where is this ulcer? The ulcer is at the medial side of the lower part of the leg. In respect to the medial malleolus, then it is behind and above the medial malleolus. This ulcer looks what? This ulcer looks elongated in shape, and it is about 7 centimeters longitudinally and transversely in its maximum dimension about 4 centimeters. Then we can look here about the edge of this ulcer. We can see that the edge of this ulcer is sloping. It means it's coming like that, It might be punched out straight. It might be undermined. If we put our finger here, we can elevate this part of the skin, undermined here. It can be rolled out like that, or everted. The edge can be showing nodules. Here it is not like that. Here it is a sloping edge, as we can see it all around. Then we are going to see how deep is this ulcer. This ulcer is actually about half a centimeter in depth, and its floor is covered by infected granulation tissue. As you can see, this granulation tissue are the red parts, and the yellow part is the exudate, which is rather septic exudate here, yellowish in color. So this is the floor of the ulcer. The base is what the tissues are, and this base you cannot comment on except by palpation. Here we can, after that, see how we can comment on this. Then we look about how is the margin. The margin is the area of the skin around the ulcer. The margin of the ulcer, can we see here? Can we see here? It is pigmented. These whitish parts are fibrotic, and these parts are pigmented, and the skin here is excoriated, and from the fibrosis we can even find that there are contractures here of the tissue. The tissues here are fibrotic and turgid all around. There could be an edema of the foot itself, and we can see here that this foot looks different than the other foot. Even the skin here is dusky, and the foot here is edematous, is bigger than the other foot itself. What was this? This is scarring. There is a lot of scarring, mostly of the medial side. The lateral side does not show these scars, but on the margin we can find this scarred skin is easily traumatized. There is another small ulcer here. This is easily traumatized. So this is the description by inspection of the ulcer itself. Here we can describe the rest of the lower limb. Now we can see things other than the ulcer itself. We can see here a prominent vein at the site of the long saphenous vein, bunch of vein along the course of the long saphenous vein. Then we know that this is a venous type of ulcer. Actually, these ulcers occur with the secondary type of varicose veins, where there is a chronic venous insufficiency. If these varicosities were primary varicosities, very rarely do we get a venous ulcer. So these varicosities are actually secondary varicosities, and this is a venous ulcer due to chronic venous insufficiency. Then we have to look before from the back here and see what else, because there might be other lesions here. Here we cannot see any short saphenous system. We cannot see any short saphenous system, so these secondary varicosities are due to the long saphenous system. Then we are going to palpate for this. The palpate for this actually, is it tender or not? We ask the patient before we palpate, and you see the induration around the ulcer here, and then we palpate at the base of the ulcer. If it is tender or not, we look at the patient himself, and is it nodular, indurated or not? And we commented already on the discharge. We can see discharge on our finger, or we can swab the discharge and see and send it for bacteriology, for example. Then we are going to examine now the venous system, as we said. With the venous system, when we come to examine it, we will have to be at the same level and squatting like that in front of the patient, and then we are going to palpate over the course of the long saphenous vein. Here we can see the bunches, the elongated, tortuous, dilated veins along the course of the long saphenous system, and we say that these varicosities are both below and above the knee. And we carry on till we go to the inguinal part here. And in the inguinal part, in the femoral triangle, we feel for a varix, which might be a dilated part of the upper part of the long saphenous, the saphenous varix, or the long saphenous itself shows an incompetent saphenofemoral valve. We ask the patient to cough and feel if there is a thrill or not is there. ممكن تكح لو سمحت؟ كح؟ كمان مرة؟ Yes, there is a thrill which is felt here, means that the saphenofemoral valve is incompetent. And you carry on with all the tests that you would like to have for a varicose veins, that you know, the Trendelenburg test and the other tests of the multiple tourniquet test and so forth. But now we are concerned with this ulcer, which is due to chronic venous insufficiency. Now, if we are having an ischemic ulcer, where should it be, this ischemic ulcer? We will find it. We will find it not in the medial side, we will find it at the lateral side. We will not see these skin changes at all, and it is going to be a punched out ulcer, ischemic ulcer, punched out, and the edge of the ulcer will be punched out. It's going to be a deep ulcer. It's going to be a longitudinal, sometimes serpiginous ulcer, and the base of the ulcer is going to be exposed. So the floor of the ulcer itself is its base. We can see the tendons, maybe we might see the bone itself, and there will be no attempts of healing like in the venous type of ulcers. So this is going to be the typical part of the ischemic ulcers, the lower part of the leg and the lateral side, while the venous ulcers are towards the medial side and the lower part of the leg too, at the ankle perforators. Then, of course, we are going to feel for the inguinal lymph nodes, and these inguinal lymph nodes might be tender in acute infections, superadded secondary infection, and sometimes they are showing chronic hyperplasia of these lymph nodes, and they are going to be firm, enlarged, and discrete lymph nodes here in the inguinal area. Sometimes these lymph nodes will progress to an inguinal abscess if the infection is severe and there is lymphangitis and severe lymphadenitis secondarily to these infections. But sometimes we will feel that these lymph nodes are now hard, and if they are hard, maybe we can feel here also that the base is very hard and indurated, and the edge is not anymore sloping edge, the edge is everted. Although the patient is known to have a long-standing venous ulcer, this is a bad sign because it shows that this ulcer has changed to a marjoline ulcer or a type of squamous cell carcinoma that occurs on chronic ulcers. And in this case, it is going to be handled as if it is, not as if, like it is now a malignant, not anymore a venous ulcer. So that was, in short, the examination of an ulcer. We can do the same thing while the patient is lying down, so you don't have to squat, but you will have, of course, to let the patient stand up once more in order to feel the veins. Never forget to see the pulsations, because sometimes venous ulcers are there, but the limb is also ischemic. Not only there are varicosities. Sometimes varicosities exist with ischemia. So in this case, you will have to, in all cases actually, you do not miss to palpate for pulsations, the dorsalis pedis here, and if you are feeling, you know how to examine. You feel the dorsalis pedis, the posterior tibial, you go to the popliteal if these are not felt. So we always feel it from distal to proximal, and while the patient is lying down, we see for the edema. Now the patient is not having an edema actually. This is having extensive scarring that we are going that we have seen and examined. Thank you.